I'm Dr. Jeanette Ross. I'm a geriatrician and palliative medicine specialist, and I'm going to talk today about falls and hip fractures. Apologize for the delay started. I know I'm in between you going home. But thank you for staying and hanging in there. We are going to show a video in a minute that we produced, and so we had some technical issues that I had not anticipated playing that. But as you can see in the slide, the objective for the session is to recognize the impact of falls and hip fractures in older persons, and we're going to describe how to assess and prevent falls in elders, and we're going to highlight some evidence-based components of caring for patients with hip fractures, both in the hospital and outpatient setting. So first, we're going to show you the video. Go ahead and switch it, Joe. So this is a video that I made with funding that I got from the UT system, and it's kind of loosely based. Both my mother and my mother-in-law fell 2 years ago within 1 month of each other, and so I was already interested in falls, but this kind of made me want to.
Well, my father's fall was a very intense experience. You know, the most frustrating part was it could have been prevented had we taken the appropriate measures. It started 4 weeks ago. It was just another typical night at the Garcia household until
This Chihuahua. Grandkids.
Oscar. Oscar.
Ay.
Oscar, what happened? What were you doing? Let me try and help you. Come on. Let me try and help you. Come on.
I can't. Just forget it.
Come on. Let me help you. Come on.
Just call 911.
Oh. Okay. Let me call him. Just let me call him. Let me call him.
911, what's your emergency?
Hello?
911, what's your emergency?
Yes, my husband fell. He's on the floor. I need help.
Sir.
Oh, yes.
Sir.
Oh.
How you doing?
Oh, I don't know. I think I'm okay.
You fell down? Look at me.
Yeah.
You fell down?
Yeah.
Okay. You all right? How you feeling?
I'm okay.
What's your name?
Oscar.
Okay. Oscar? We'll
yeah.
be okay. Did you fall and hit your head?
No, I don't think so.
Okay. All right. Why don't you just relax?
Oh.
BP is 110/80, heart rate 90, respiration 20.
His glucose level is at 80.
Is he okay? He's stable for now. It's a good thing he didn't hit his head.
No, I just slipped and fell. That's all.
We need to take him to the ER for an evaluation.
No. I'm okay. I'll just go see my doctor.
We will. He has an appointment coming up next week.
Okay, but make sure you take him.
I'll get up. Yeah, right. Oh.
It was such a struggle to get him to go, but we were able to keep the appointment.
Yeah, but it was just a waste of time.
No, it wasn't, Oscar.
Yes, it was. Doctor wants me to do exercise. Exercise at my age? Then she said there's something wrong with my balance. There's nothing wrong with me. I just fell. And then she mentions this Chinese thing for balance. Tai Chi or Chi or something. And no way. That's some other kind of people.
They weren't exercises.
Okay, so what brings you in today, Mr. Garcia?
¿Por qué no le dice que yo no quería venir?
No. Oscar, you need to tell her. Tell her.
Well, I kind of fell last week.
Oscar, you did fall.
Okay, tell me about your fall.
Well, it's her fault, but I mean, I got up, like always, go to the bathroom in the middle of the night. And I was okay. I went to the bathroom and just hollering.
Mr. Garcia's case is actually really common. The fact that he has fallen in the past and fallen recently. In fact, the single most predictive prognostic factor that a person is going to fall is that they've already fallen. So when you're screening for elderly patients who will probably fall, you need to ask if they have fallen in the past, especially since the last visit, if you see them regularly. And if they're a new patient, you can ask if they've fallen in the last year. In regard to the fall, you want to know whether there was loss of consciousness, did the person have lightheadedness or palpitations, whether the person tripped or stumbled over something, if they were able to get up within 5 minutes, and if they required assistance to get up. You also want to ask about other potential contributing factors, like drinking alcohol or conditions that may impair gait, like Parkinson's disease. Okay, so can I take a look at the medication that he's taking?
Yes, here you go. He's still one ton.
Of course, that's what you're taking. And I know they look messy, but my daughter wrote on the bottles to let us know what she needs to take each time. She even got him a pill box.
Yeah, but I know exactly what I'm supposed to take. I take the little blue pill I take for urine, for my urine, and the purple pill I take for my stomach.
Okay. Well, your physician is going to want to look at what you're taking anyway, just to make sure that there's no side effects that put you at risk for falling.
And what? I'm supposed to stop taking them? I mean, don't I need them?
She won't take you off of any of them. It's just good to be aware so that there's no mistakes. You should also note if the person uses any assistive devices, such as a cane, walkers, or wheelchairs. It's important to check for vision problems that may be contributing to falling. To check the visual acuity with a Snellen chart and examine the eyes for cataracts or other physical problems that may be interfering with vision. You want to see if orthostatic hypotension, which is blood pressure lowering when standing, is a contributing factor. You can check for that by taking their blood pressure in a lying down position and then 2 minutes later when they are standing.
Well, as his primary care provider, when I walked into the room, I could tell Mr. Garcia was a little sensitive about the fact that he had fallen. And as with most patients, it can be a little bit embarrassing, but it's a very serious matter nonetheless. Well, in my initial assessment, I discovered that Mr. Garcia had fallen 3 or 4 times in the past year. The falls had happened under similar circumstances, getting out of bed at night, in poor light, bumping into furniture, pets, and other clutter. However, he was usually able to get himself up until this last one.
No big deal, Doc. I'm an old man. I think it'd be weird if I didn't fall every now and then.
Well, have you noticed that this happens any particular time of day? For example, after you take your medications?
It's funny you mentioned that. Every time he takes his orange pill, he gets woozy.
The orange pill?
Yes.
Can you show me?
Hey, this one.
Well, this is hydrochlorothiazide or thiazide. It's a diuretic or water pill. And this medication, while it is useful to treat blood pressure, can cause your blood pressure to drop too much when you stand up. And that can increase your fall risk. Well, sometimes patients may not be aware, but certain medications can lead to falls. Some cause dehydration, increased sedation, or can lead to hypoglycemia or low blood sugar. In Mr. Garcia's case, medications like hydrochlorothiazide, glipizide, lorazepam, and spironolactone, and terazosin could all have been contributing to his falls. Well, for Mr. Garcia, we performed the time to get up and go test, which is an important office-based measure of mobility. It's a quick, easy test you can perform in the office to assess a person's ability to stand, walk, turn, stop, come back and sit down. And usually individuals should be able to do that in 7 to 10 seconds. So if a patient can complete that test in 10 seconds or less, we consider them to have high mobility. Folks who take a bit longer, 10 to 20 seconds, are considered at risk. And folks that take upwards of 20, 30 seconds to complete the test, that's considered somebody who's almost a non-functional ambulator. Mr. Garcia, I'd like to do a quick test to check your mobility and your balance.
Okay.
When I say go, I'd like you to stand up without using the armrests if you can.
Oh, I don't know if I got the strength for that, but...
Well, if you need to,
Okay.
go ahead and use the armrests. I'd like you to
Okay.
stand up, walk 10 feet or to the black tape, turn around, come back, and sit down.
Okay.
We'll start whenever you're ready.
Okay. I'm up. Okay.
Okay, 28 seconds.
Okay. Was that a good
Well,
time?
that suggests there might
Record-breaking?
that suggests there might be a mobility issue here.
Oh, okay. Well,
Yeah. Well, after the initial assessment with Mr. Garcia, often we're able to make several recommendations. I often show patients how to appropriately use a cane or walk or other assistive devices. I also discuss the importance of neck alert bracelets. This is a bracelet that can be worn around the neck, and if a patient falls and is unable to get up, they can call for assistance. As in the case of Mr. Garcia, I also often refer patients to physical therapy so that they can learn gait and balance exercises, and I might refer them to an occupational therapist who can perform a home safety evaluation. Well, Mr. Garcia, I'm so glad you came in today so we could talk about your falls and ways that we can reduce the chance you'll have another fall in the future. I have several recommendations I'd like to make. First, I'd like to refer you to a physical therapist who can work with you on your gait and do some balance and strength training. I'd also like to provide you with a safety checklist so that you can look around the home and identify any hazards or things that might be increasing your fall risk at home. I think we also need to talk a little bit about your footwear. It's better if you can wear footwear that's going to support the whole foot. Those flip-flops you've got on today are increasing your fall risk. I'd also like you to think about looking in the community to see if there are any Tai Chi classes that you might enroll in to improve your balance and your strength. Okay? I'm also going to recommend that you see the eye doctor to update your eye exam and evaluate your cataracts. Okay?
okay.
And I'd like you to start taking calcium and vitamin D supplements to strengthen your bones, right? And as I mentioned, we're probably going to need to stop your hydrochlorothiazide, the water pill you've been taking. It's very useful to treat blood pressure, but sometimes it can cause your blood pressure to drop too much when you stand up. This can increase your fall risk.
Here, I thought it was all them rugs you put all over the place. I
me.
trip on them.
Balance problems in the elderly come from multifactorial problems, but mostly they come from having weakness in their lower extremities, particularly in their hip girdle, core strength, for example, their gluteus maximus, gluteus medius, their hamstrings, quadriceps, their tibialis anterior muscles. It also comes from joint mobility issues such as, joint pathology or joint replacements. Also, a lot of the elderly fall because of a decline in their sensory systems. Just as we age normally, there's changes in the sensory systems. You lose vision, there's decrease in your vestibular system, you have decrease in your somatosensory, so you have decreased sensation from your joints, or you have decreased kinesthetic awareness of where you are in space. All of those sensory deficits contribute to problems where they can't necessarily compensate for changes in their environment or any kind of integration of their sensory systems to avoid a loss of balance.
One thing my father loves more than being stubborn is his plants. It's almost impossible to keep him away from them.
Maria! Maria!
Oh, man, what are you doing outside? The doctor told you shouldn't be doing any physical activity.
The doctor wouldn't think watering plants is physically demanding. I've been doing this all my life. Hey, do you know if we got any more weed killer?
I don't know, but if you're gonna be out here, don't drown my flowers.
Always got something to nag about. Maria! Maria! Maria!
It must have been a week after that visit that I received a phone call. It was one of the scariest days of my life. When I got to the hospital, my father was still in the ER. I could see my mother was distressed as my father just lay on the stretcher.
Hi, Mom.
Hi, Mija, you made it in.
Yeah. Hi, Dad.
Hi, mija.
How are you feeling?
I'm all right. I'm tired of waiting for the doctor.
Sorry for the wait, folks. How are you feeling, Mr. Garcia?
Oh, you tell me, Doc.
Oh, I'm sorry to have to tell you. You have broken your right hip.
Oh.
And more specifically, you've broken the femoral neck.
Oh.
I'm sorry, sir?
Oh, I didn't know it had a neck.
It has a neck. It's just one end of the bone. But what that means is that you're going to have to go to the operating room to have a surgery to repair this.
What? No duct tape?
I'm afraid that duct tape won't do it this time.
Is he going to be in the hospital for a long time?
Well, we'll admit him tonight, and he'll have the surgery tomorrow. The surgery itself takes a couple of hours, and I would think that he'll need a couple of days in the hospital after that. He may need to go to rehab for a little while after he gets out of the hospital.
Oh, I guess that's not too bad.
I don't think it's too bad, and we have a really good team here to take care of you.
My father's surgery was successful, but the next 2 weeks of physical therapy really tested him.
Mr. Garcia was tough. His personality made it a little hard for him to fully participate in his rehabilitation. But for a man of his age and with his injury, he toughed it through.
Okay, you're gonna make me well.
Yes, sir, I am. All right,
gonna
so
hurt me?
no, not any more than I have to.
Okay.
So the acute phase of rehabilitation is real important. We have a very short period of time to really figure out, what the patient's needs are going to be, and we have some very specific goals that we try to get through. When we look, in the first part of the rehabilitation. We're trying to prevent wound complications, make sure that they're healing correctly. We also try to instruct them in their weight-bearing precautions because that's also something that helps them to heal, prevent any complications. We also look at teaching the patient transfer skills and self-management skills that they're going to need, as they continue to progress through their rehabilitation. We also look to improve their ambulation, typically with an assistive device, a rolling walker or standard walker. We also look to prevent hip flexor contractures because that's something that could limit their progress. We try to instruct their family in ways that they can help and things that they should avoid, as they move through their rehabilitation with their goal of heading home. We also try to increase their lower extremity strength in the knee and the ankle muscles. We look at, increasing their passive range of motion, particularly, or active assistive range of motion if possible, in the affected limb. We also look at strengthening their upper extremities because they're going to need that kind of strength in order to use the walker. Mr. Garcia is definitely not used to supporting his whole body weight, through his upper extremity.
Okay, next, let's discuss Mr. Garcia's discharge planning. As you all remember, Mr. Garcia is the gentleman that had the hip fracture that has now been repaired. And I think that the physical therapy has helped him significantly, but he is not functional enough to be discharged home safely.
I agree. We've been working on mobility exercises, strengthening, been teaching him how to use this walker, but he still needs a lot of assistance with his activities and he's not safe. At the same time, I don't think he's strong enough to go through the 3 hours a day of physical and occupational therapy that he'd need to go through at an inpatient rehab facility.
So are we suggesting a skilled nursing facility or subacute?
What is that?
A skilled nursing facility, or a SNF, is an inpatient institution which provides medical, nursing, and rehab skilled care. This is where the patients go to recover. And these skilled personnel are required to meet the needs of the patient, promote recovery, and ensure medical safety.
So someone like Mr. Garcia might get 6 days a week of about an hour of physical therapy and occupational therapy for about 4 weeks, and then he could be discharged home to do outpatient physical therapy.
Okay, let's have the Garcias talk to our social worker and look at some skilled nursing facility. All right, next we have Mrs. Jones.
At this point, my father was terrified of falling again. Once my father was discharged, we all knew certain adjustments would have to be made to help him in his physical and mental recovery. We were also referred to home health and safety personnel who came to inspect my parents' house.
I finished my evaluation. Come with me so I can walk you through what I found.
Okay.
So, first things first. You need to be aware of water on the floor. Secondly, place a non-slip decal or mat in the tub to avoid slippage. I'd also recommend a nightlight. What I see here is a tight space between the bed and other furniture. And there are items on the floor, including clothing. And things like this cord to the lamp are easy tripping mechanisms. And we need to ensure that all of the throw rugs, they're fastened down with double-sided tape. We might want to consider placing a urinal by the bedside. I was about to mention this. This pet food is too close to the path that one takes to enter.
A falling hazard.
Exactly. We just need to move it someplace. The same is true for these rugs as in the bedroom.
So I need to buy a lot of double stick tape then, and make plans to modify the rest of the house for safety.
It's always a transition to make a home a safe environment, but in the long run, you're providing your parents with the opportunity to stay in their home.
Thank you. So it's been small changes here and there, but so far it's pretty good.
It looks good there. Just put it down. It looks good right there.
My dad is still active when he wants to be and finds a way to make the most of his days. But he can't get too far without his personal bodyguard. Although my father's fall was a scary experience, I'm grateful to the team of healthcare providers that were there to look after him and bring him to a speedy recovery.
I'll sign all of at the end. For my brief, before we move on. So since we had technical difficulty, I'll just kind of skip forward some of the concepts. Can you hear me? We'll just skip forward some of the concepts that we kind of discussed in the video, just the brief highlights, the definition of a fall, like that third definition, that's the unintentionally coming to a rest on the ground floor or other lower level. Falls are very common. They're frequent common cause of death in older adults. Well, accidents are common, the fifth cause of death, of which two-thirds of those are actually a fall. And as we look at people that are getting older, falls are more common. And some of these falls result in hospitalizations, as in our movie case. Some of these people that are hospitalized, about half of them will not be alive a year later, so those falls are pretty severe. And not just a fall on the broken bone itself, but traumatic brain injury as a consequence of a fall can be fatal as well. And this is expensive. Now, hip fracture, the biggest risk factor for hip fracture is falling, so that's why they kind of go together. And these hip fractures also have high mortality and in older adults, and especially when we're looking at the 85 and older, they have 10 to 15 times the risk factor of a person 60 to 65. And there's a lot of functional decline as a result of hip fractures. They are not able to perform their activities of daily living, and some of them need to be institutionalized, and there are actually a significant number of deaths associated with hip fractures. So just gonna kind of skip, but this more or less was discussed in the video. Basically, we need to maintain our balance. We need our vision, our balance, and our sense of position, and also good musculoskeletal function. And all of these are diminished in older adults because of osteoarthritis and diminished receptions, and then like vision, we have like macular degeneration and other cataracts and other problems, medical problems that impair the vision. I think we just kind of addressed that during the video, so I'm just going to skip that. This is the history. We addressed that in the video. Again, you want to look at all the factors related to the falls. Are there any medications or vision, assess their gait and balance? And then the physical exam is focused towards assessing the joints, brief neurological assessment, and to identify any cardiovascular causes. And then just a quick reminder of how to some gait and balance tests, the Romberg test, and then this is the graph that you're seeing right there. This is the Thiel-Halpike test, and this is to identify benign positional vertigo. It's something that you can, so you sit the person and you move their head 45 degrees, and then you quickly tilt it down, and if their eyes, they have the nystagmus, so they have that dizzy sensation again, then it's related to the position. And the good news is that some of us respond to maneuvers, and my husband had that benign positional vertigo, and that's how I met the therapist in the video, Chera, and it was amazing that he was like dizzy, laying down, she diagnoses, she did the, I'm blanking on the name of the maneuver, it'll come to me. Huh? The Epley maneuver, I think he is. And then he was like 90% better. And the same thing, with older people. I mean, it's just oscillate in the vestibular system, and it can cause impaired use significantly. And I've done those a couple maneuvers. There's some good YouTube videos where there's instructions on how to do it, but you can also refer to your physical therapist as a resource. The get up and go test you saw in the video, and again, the slower, the longer it takes you, then the higher risk that you are of mobility, and it's important to identify those people that may not be safe ambulators and intervene on them. And it's something that, sort of informally you can perform in the clinic when you ask your patient to come to the room. I mean, you're coming from the exam room to the room, you're more or less seeing what they're doing. So I usually don't do like the formal, but more or less informal. I get a gauge of how they're doing from when I call them from the waiting area towards the room. And you can interfere there because, as we said in the video, it did like big meta-analysis, look at all these studies and what are all the factors and balance and all these other things, medications. But the most predictive things that you're going to fall is that you've fallen already. So don't forget to ask your older adults if they've fallen. And actually, that's one of our, it's a newer performance measure, one of those reminders on people 75 and older that you must ask them if they've fallen. So I don't know if you've changed your template since CPRs, but you should be attentive to that reminder, the people's and a quick get up and go. If you do a get up and go and they are fine, then you're good, you're done with the testing. Only if the get up and go is abnormal is when you need to go find something else. So it's a quick way to, again, it's a screening, but if they test well, then you're done. As far as laboratory testing when you're working at falls in, I mean, most of them, unless you identify something specific in your physical exam, nothing's going to really be, nothing's like a mandatory part of the workup unless you identify something else where you're suspecting a cardiac arrest reason, then that's when you would order Holter or otherwise, but mostly based on what you're suspecting. Also, if you think that the patient may be anemic or dehydrated, then a simple chemistry and CDC can help you. And these are just a summary of the prevention of falls from the American Geriatric Society and the British Geriatric Society. So again, the most important thing to assess everybody, whether they've fallen, and then for the assessment if they've had a history of falls. Exercise for strengthening and balance is very important, as we saw the examples in the video. Environment, because you want to diminish everything that's contributing. You want a good lighting, decrease the cluttering, medication review that may be causing fall risk, and then if needed, assistive devices. The behavioral education programs are also related to the fact that some of these frequent fallers, then they become very afraid of walking because they're afraid of falling again. And this kind of, then they're less active, and then when they're afraid of falling, and you don't really want to get into that vicious cycle, but that's kind of what the behavior and education, just kind of dealing with that fear of falls. And then just a brief, some brief pearls on hip fracture care. You consider their surgical risk, and the higher surgical risk, the ASA 3 or 4 have a 9-time mortality compared to the categories 1 and 2. And you also want to consider, the whole patient, if they have advanced dementia, if they already had poor baseline functional status, is this hip fracture surgery and going to put them at risk? I mean, if they're not going to be able to do the rehab, they were already not functional. You're going to have to weigh in the pros and benefits. And then just a brief summary of the As far as the time surrounding the care, you have to decide whether you're going to do a surgical versus non-surgical approach. Make sure that you optimize the medical abnormalities as much as possible. You want to put prophylaxis for venous thromboembolism, such as low fractionated heparin, antibiotics to prevent infection, and usually this is like a first generation cephalosporin. You want to prevent pressure ulcers, and then you want to have to think about the type of anesthesia. For some of our older people, they already have some cognitive impairment, and so regional may be better as far as less chance for confusion than the general anesthesia. And then post-operative, you want to make sure you have adequate pain control, and I'll say a little more on the next slide. You want to prevent delirium, so make sure they have their glasses, that they have hearing aids, that they have proper lighting, that they have environment proper for sleeping to keep the proper sleep-wake cycle. You keep track of how much they're eating and their outputs. As far as anemia management, unless, typically you want to keep the hemoglobin higher than 8 with transfusion, but if they are like between 10 and 8, but they have no symptoms, then you may want to hold on until it's under 8 of the hemoglobin. And very important thing with the post-operative is to remove the urinary catheters promptly, because you really want them to start breathing on their own again. And that's, the catheter is something that's interfering a little bit with their rehabilitation, and you really want them to go back to independent urination. As far as why the pain control is very important, there was a study where they looked at 411 patients that have hip fracture, and it's significant that most of them had pain that was undertreated. So about half of them were in moderate to severe pain, even at rest, just laying there, and then when they were receiving their physical therapy, that went up to 90%. So if your pain is not controlled, then you have longer length of stay, then they can't go to physical therapy because they can't participate, and then they can't ambulate, and so that decreases their function. Now, usually there's some rehabilitation to be done post-discharge, and depending on their previous functional status, sometimes that could be either at home or sometimes in a facilitation facility. You also want, somebody's already broken a bone, that means that their bone health is poor, and you want to make sure that you tend to their bone health and consider bisphosphonates and vitamin D. And then, so in summary, gait disorders are associated with many diseases and syndromes, including falls and hip fractures, and falls by older adults are common and usually multifactorial, and screening and targeted preventive interventions are most effective in management falls. And you want to comprehensively manage hip fractures to decrease disability. And that's it. Oops. So I'll take any questions. Any questions from the audience at this time?
Okay.
Well, thank you.
Thanks.
We'd like to see you tomorrow for more sessions at 8?
8.
Okay, see you tomorrow. Thanks.